Hi, friends. This is Osheen, and I am looking at how to treat obsessive compulsive personality disorder with psilocybin in my clinical study. And here's my presentation. Before I begin, I would just like to acknowledge that we are on the Musqueam land, and this photo was taken on one of our classes, decolonizing walk, and thanks to the Belkin Library. And I just wanted to say that the Musqueam people are still here, still present, and we need to acknowledge their land. I would also like to acknowledge the origin of psilocybin assisted therapies. Unfortunately, Gordon Wasson gets the credit for jumpstarting the psychedelic revolution, but writing about his life changing experiences with psilocybin mushrooms would not have been possible without Maria Sabina, who is an indigenous Mazatec curandera who actually took him on his first journey. So, this is my positionality statement. I would just like to say that I'm a settler and I'm extremely grateful to be doing this research with Indigenous medicine on Indigenous land. So, what is OCPD? OCPD is a mental health condition that causes an extensive preoccupation with perfectionism, organization, and control. It's actually a personality disorder. The prevalence is about 2 to 8%. It's diagnosed more in men than women, male and female. And unfortunately, I did not find a lot of multiracial data and queer data. Also, there is a difference between OCPD and OCD. So, a lot of people get confused between this. So, I just wanted to mention that people with OCPD are actually unaware of their preoccupation with details and order, but people with OCD are aware of their compulsive behavior. For example, turning off and on a switch 3 times before actually turning it on. So the current treatment that is provided for OCPD is cognitive behavioral therapy, SSRIs, and also some meditation. And I wanted to list the comorbid disorders here because anxiety, depressive disorders, and OCD are hereditarily linked, and one can see that when there is compulsion to do something and when it's not done, it definitely can give a lot of anxiety. The default mode network. So, the default mode network consists of the inferior parietal cortex, posterior cingulate cortex, medial prefrontal cortex, anterior cingulate cortex, and medial temporal lobe. It is best known for being active when a person is not focused on the outside world and the brain is at a wakeful rest, such as during daydreaming, mind wandering. It can also be active during detailed thoughts related to external tasks or performances. Other time that the default mode network is active is to include when the individual is thinking about others, thinking about themselves, remembering the past, and planning for the future. And this is where the issue with disorders like OCD or OCPD comes in, because the activation in default mode network is so high that the thinking about themselves turns into ruminating, and it becomes into compulsive thoughts, which, if you don't execute, then gives anxiety. So here, as we can see that Coutinho and colleagues have found that the default mode network in people with OCPD have an increase in resting state functional connectivity when they had put them with their eyes closed. And they especially found activity in precuneus. And as you can see, that precuneus is involved in recollection and memory, integration of information, cue reactivity, and mental imagery strategies. So, why psilocybin? And I just would like to say that psilocybin has been proven to reduce the default mode network activity in a good way, and which helps in reducing obsessive thinking, reassessing obsessions, and it's been proven by Carhart Harris. It's also seen that psilocybin can lead to positive states of ego dissolution that also may facilitate the cognitive reappraisal that can occur during a psychedelic experience. So I wanted to show this image to compare between the serotonergic psychedelics that I used for different things, but I wanted to show that psilocybin amongst ayahuasca and LSD has actually the best effect. There's a significant brain deactivation after psilocybin compared with placebo in the default mode network. And yeah, you can see in A, psilocybin, the blue is really less, which shows a good deactivation, which is better than ayahuasca and LSD. So my hypothesis is that psilocybin will reduce the severity of OCPD in 1 week by doing the following. So it will reduce the excessive resting state functional connectivity in the default mode network, which I will be testing by fMRI. It'll decrease the maladaptive perfectionism, and it'll also lessen the severity of OCPD on a compulsive personality scale. There will also be a cultural consideration taken. I will strive to establish a culturally sensitive study for Indigenous people and people of color, emphasizing inclusive content, diverse team of therapists, on site nurses, recruitment, and validating racial oppression experiences, while addressing the institutional resistance and fostering community outreach. And we will also make sure to have cultural meals and music for the participants, and try and reflect diverse multiracial data. So here are my methods. I'm taking 50 people with OCPD, suffering with OCPD, and randomly dividing them into an experimental and placebo group. And then fMRI, the compulsive personality, and the perfectionism scale would also be used, and the placebo is niacin. The covariates of the study is gender, age, and ethnicity. So the eligibility criteria is here. The inclusion requirements are that you have to be 18 years and above, you have to qualify for the symptoms of OCPD, especially aggressiveness and perfectionism, and you have to be distressed with symptoms. The exclusion criteria is as follows: if you're pregnant or lactating, if you're on SSRIs or antipsychotic medication that cannot be discontinued, family history of bipolar, schizophrenia, delirium, hypertension, and extreme sensitivity to drugs. People with these things will not be able to participate in the study. So here is how the stages of the psychedelic therapy will look like. There is a preparation session, a dosing session, and then integration. So this is the procedure. It's a 1 week double blind study for people with OCPD. After being screened and taken informed consent, participants will be randomly divided into two groups: niacin and psilocybin group, which is the placebo, and experimental group respectively. And day one, they will be introduced to psychedelics harms and benefits. And the reason I'm doing that is because a lot of people still don't know about what psychedelics do and how they help us. So I would just like to give back to the community by letting them know about what they're getting into. I would also reassess their willingness to participate in the study after letting them know about the harms and benefits. And then the first day will also be doing an fMRI, which is the baseline measure to see the resting state functional connectivity in the default mode network with eyes closed. They will also be creating intention, integrating one-on-one with the therapist, and giving the compulsive personality and perfectionism baseline measures as well. On day two, it'll just be about setting intention. They can do it one-on-one. They have to do it one-on-one with a therapist. We will assess fears again going into the psychedelic of them going into a psychedelic journey, just to ease the anxiety and probably give them some breath work and some techniques on how to deal with challenging trip. On the third day, they will be given psilocybin. I'm using huatla mushroom, which actually comes from Mexico, Oaxaca, and the session will be with 2 to 4 grams of psilocybin mushrooms. It'll be based on the body weight and people's sensitivity to drug. And placebo will get the niacin capsule, and it'll be an 8-hour session with blindfolds for both the groups. Culturally sensitive music will play, and they will always be supported by at least one therapist, but two therapists will be present at all times mostly. On day 4, they will journal and reflect on the experience that they had with the psilocybin, and then they will integrate that with the therapist, reflecting on the processing of emotional expression. And they will also do the FMPS and CPAS measures after the journey. And on the last day, they will do the fMRI measure again to see the resting state functional connectivity in the default mode network. And that's the end of procedure. As a token of appreciation, they will be given some lion's mane mushroom to maintain healthy immunity and cognition, some candles, dried flowers, and a journal so that they can continue a habit of journaling. So, my expected results are that there will be a happy, relaxed default mode network. There will be a reduced resting state functional connectivity in the default mode network. There will also be reduction in maladaptive perfectionism, and there will be decreased severity of the OCPD on the compulsive personality scale. There are some limitations in the study, like small sample size. Niacin effects is always very, very different from psilocybin. And the MRI is also known to have a lot of noise and uncontrollability. And there are other limitations like participants' bias and stigma toward hallucinogens in the BIPOC community. The future studies can look at qualitative studies like taking notes of the mystical experiences and actually seeing how the psilocybin journeys have been helpful. Microdosing with psilocybin can also help with OCPD, but it has to be a longitudinal study, at least 3 to 6 months follow up, and a longitudinal study with macrodose can also be done at 6 months and 1 year. Before I end, I would just like to share this quote by Natalie Leila Ginsberg. I figured psychedelic therapy must be addressing the root of the problem rather than suppressing the symptoms. I think this speaks a lot to my research project. Thank you so much. And if you have any questions, please email me. Here are my references.